So again, guys, assalamu alaikum. Sorry for that technical difficulty. So again, to begin, my name is Abdulaziz Alaklabi. We have Faisal Alkhwaiter with me as well, and we'll be covering the OSPE, inshallah, the OSPE review for CVP. So to begin, we're going to start with the heart orientation, all right? So basically, to start off is the apex, of course, is going to be down and out. So this is the apex of the heart, okay? The anterior interventricular groove is what separates the right from the left ventricle, okay? And we can see the pulmonary trunk, which is going to be anterior, and the aorta is going to be right to the right of it and posterior, okay? No, So, what we see right here is going to be the pericardium. Okay, this is what we see. This is basically the fibrous pericardium. It's essentially a sac. Can you guys see my drawing, by the way? Just making sure you guys can see what I'm doing.
Yeah, we can see.
Okay, perfect. So this is essentially the fibrous pericardium. It's a sac that's covering the heart. If you were to open the heart in, for example, cardiac surgery, this is essentially what you would cut open and you'd separate, and inside you'd see the heart. Okay, so you would cut open the fibrous pericardium. So this is right here is the fibrous, okay? The second layer of the heart is what we call the serous pericardium, okay? And it's divided into two layers. It's the parietal and the visceral layer, sorry. The parietal and the visceral layer. So these layers you cannot see. They're directly attached to the heart. So it looks like there's nothing on it. So they're not visible. However, the fibrous is very obvious that it's the sac that's covering the heart. So if you were to see something, that is definitely the fibrous pericardium. Okay, so right here we have some questions. So first of all, sorry, you guys just saw that answer. We're going to talk about the borders of the heart. So can anyone tell me what the right border of the heart is?
It's going to be the right ventricle.
The right border of the heart is going to be what is lying right essentially lateral to the lungs, or right beside the lungs. So when we talk about the right border, the right ventricle does somewhat create that border. However, it's actually the right atrium. So if we look right here, so here I can show you a nice drawing. So essentially, the border, when we say right border, we have four borders, essentially, or five borders. This is the left side, this is the right side, the inferior, okay, the superior, and the apex. So these are essentially five borders, okay? So if we see here, the right side of the heart, what's going to be lying there is going to be essentially the right atrium and the superior vena cava and the inferior vena cava. Is that clear?
Yeah, it's clear.
Okay. So can anyone tell me what the left border of the heart is? Or what makes the left border?
It's going to be the left atrium and left ventricle.
Amazing, perfect. Okay, so we can see again right here, this is a little bit of the left atrium, which is the left atrial appendage, and the left ventricle. So these two structures make up the left border of the heart. Now, can anyone tell me what makes up the inferior border of the heart?
Left ventricle mostly.
Yeah, so actually it's going to be both. So it's going to be the right ventricle and the left ventricle. So they make the inferior border. So both are going to actually make the inferior border. Okay. And what do you guys think makes up the superior border over here? This one's a little bit difficult, but essentially. Sorry?
Roots of the great vessels?
Yes, perfect, mashallah. So essentially it's going to be the right atrium and the right atrium, sorry, the left atrium and the great vessels. So the aorta and the pulmonary trunk. So these are going to make the superior the superior border of the heart. And of course, the apex right here is only made up of the left ventricle only, because we can see here, this is the interventricular sulcus, and this right here is the apex, and that's only made up by the left atrium, the left ventricle, sorry. Now for the surface of the heart. Okay, so we talked about the borders. Can anyone tell me what the anterior surface of the heart is?
The right ventricle.
Perfect. And this is a very important reference point when we go to the echocardiogram and the images of the heart. So it really helps us have like a nice base and a nice visual orientation of what we're looking at. So yeah, again, the right ventricle is making up the anterior surface. So I don't know why this is going automatically, but can anyone tell me what makes up the posterior surface of the heart? Yes, that's going to be the left atrium. So I'm also looking at your guys writing in the chat. So you guys can keep writing, and I'll inshallah see your answers and stuff. Okay, so yes, so the left atrium is going to make up the posterior surface. The inferior surface type is made up by what?
The left ventricle.
Yes, is going to make up the essentially. This is going to be the left and right ventricle. So both are going to make the inferior surface. The inferior surface is going to be majority left ventricle, but also right ventricle. The right pulmonary surface is going to be made by what structure? What do you guys think?
Right atrium.
Great. Okay. And the left pulmonary surface is going to be made by what?
The left atrium.
Close, but it's also going to be similar to the border. So it's going to be the left ventricle, actually. Because if you can see right here, with this structure, you said the right atrium, right? Is going to be attached to the lungs. So this is going to be where the lungs are. Okay, صح? So that's going to be the structure. So if I had the left lung over here, what structure is going to be beside it?
Oh yeah, it's going to be the ventricle. Yeah,
exactly.
Gotcha.
Okay, does that make sense? Okay.
Yeah, it makes sense.
Now, one more a good reference point for future for the echocardiogram when we talk about that is how essentially we're oriented in the image of the echocardiogram, which is going to be a little bit difficult for medical students. So let's have a hypothetical image. So let's say this is the esophagus right here, okay? So when we go for echocardiography and we're going to put the scope inside, we have the camera towards the heart. Okay, so this is the esophagus, this is the heart. And so basically, the first structure you're going to see is going to be what? The posterior surface, which is going to be the left atrium. So whenever you look at the echocardiography from the esophagus, which is called the TEE, or a transesophageal echocardiogram, the first structure you see is the left atrium. And the furthest structure is going to be the right ventricle, which is the anterior surface. So it really helps you be oriented. Okay. Now, for the coronary arteries, okay? The coronary arteries are very significant and very important for you guys to know. So the coronary arteries, as you guys know, are two main vessels. So the left coronary and the right coronary. And they come off from the left and right. Can someone unmute themselves? I don't know. Okay, thank you. So basically, the left and right coronaries are coming essentially originating from the cusps of the aortic valve. Okay. So essentially, what's happening is that the left coronary artery divides into two main vessels. And what are they? Does anyone know?
It's going to be the left circumflex and the LAD.
Perfect. Yes. So the left main coronary artery divides into the left circumflex, as you said, and the LAD. Okay. Perfect. And the right coronary artery is going to supply the right ventricle and the right atrium, and it's going to give off the PDA in most people, the posterior descending artery. Okay. And essentially, it's very important that we're going to talk about the significance of these vessels. Essentially, the codominance or the dominance is going to be very significant when we talk about the clinical impact. So my PowerPoint is being very weird right now, so I apologize for the technical difficulties. But so essentially, we have two arteries that supply the conduction system. That's the SA nodal artery and the AV nodal artery. So can you guys tell me which artery, the right or the left, supplies these two structures?
It's the right artery, the right circumflex.
The right coronary, yes, correct. You're right. The right coronary, you mean. So essentially, the right coronary artery supplies what? The SA node in, and this is very fast, the right coronary artery in around 50 to 60% of people, okay? So it's not a lot. It is majority, but not the most. The AV node, however, is 90%. And we'll go back and I'll show you why, and it'll make sense anatomically. So as we said before, this is the right coronary artery, and this is the left coronary artery, correct? So essentially, this is the SA node, and this is the AV node. This is where the structures will be in the right atrium. So this is the right atrium. I'm going to make a quick outline. So this is the SA node, and this is the AV node, okay? So the SA node is very close to the aorta, which the aorta gives off what? Both coronaries, so the right and left, which makes sense, which is why only 55% come from the right coronary artery, 45% actually come from the left. So both can supply. So that makes sense anatomically. Now, when we look at the AV node, however, okay, essentially it's closest to what? The right coronary artery in its path. So of course, it makes sense that 90% of the AV nodal artery is supplied by the right coronary. Instead, look at if the left coronary was to supply to it, it would have to go all the way and traverse all of this before giving off the branch, which is why only less than 10% of people have the AV nodal branch coming from the left coronary. Does that make sense, guys?
Yeah.
Okay, great. So another question is that the left coronary artery, okay, supplies all of the left atrium and all the left ventricle, except what we call a small strip of the left ventricle that's parallel to the posterior interventricular sulcus. So what artery supplies this area instead? So if the left coronary artery is supplying almost all of the left atrium, almost all of the left ventricle, except a small area which is right beside the interventricular sulcus, what do you guys think would supply this area instead? Does anyone know? Yes, mashallah. So it's going to be the PIA or the PDA. That's going to supply instead, because again, once we talk about the blood supply, the 2/3 are going to be of the IV, the interventricular septum is going to be supplied by the LAD, okay? While 1/3 is going to be supplied by what? The PDA, okay? So the PDA does supply a little bit of the strip of the left ventricle, all right? Okay, so now coming to one of the most important parts of this entire lecture is going to be coronary dominance. So I want everyone to be very clear on this and to understand why it's so significant, okay? So if you guys have any questions, please don't hesitate to ask. Perfect. Okay, so the coronary dominance refers to what? It refers to which artery is giving off the PDA. So this is gonna indicate everything. Okay, so whichever artery gives off the PDA, that is what we call dominance. Okay, so you can be what? Right dominant, left dominant, or co-dominant. So 85% of people, most people are gonna be right dominant, meaning the right coronary artery right here, it gives off the PDA. Okay, in about 15 to 20% according to the lecture, it comes off from the left circumflex artery. It gives off the PDA or the PIA. They're interchangeable names, by the way. And then co-dominance exists in about 7% or about 5%. Essentially, both arteries, right and left, are co-supplying the PDA. Okay. Now, can anyone tell me why this is so significant? Why do we care if he's right, left, co-dominant? What's the significance? Why should I care about that?
If one of my arteries gets blocked, I'll know which one to target, I guess.
Okay, very good point. Does anyone want to add to that as well? MA says when performing surgery. That is very good point. MashaAllah, tabarakallah. That is, you definitely need to know what's the dominance when doing a cardiac surgery or a cabbage. That's very significant. But what also is clinical significance? Non-surgical. Why do I care besides going to the OR? Why do I care if he's right or left codominant or whatever it is? So basically what happens is if the patient is what? If he's going to be, if the patient is, oh my goodness. So if the patient is going to be right dominant, okay, this is very significant, okay? If this artery is blocked, which is the left main artery, guess what? The septum will still get blood supply. So what happens if this is blocked, the LAD is not working, the left circumflex is not working, so 2/3 of the septum will not get any blood. Does that make sense? But guess what? The right coronary is still open, so we can still get around 1/3 blood supply to the septum. So the septum is preserved. Is that very clear? What will happen if the patient is over here? If he is, for example, left dominant. If he's left dominant, this is an extreme significance. So essentially what happens is if there's a blockage, okay? A blockage in the coronary artery. This is called coronary artery disease, okay? If there's a blockage in the coronary artery, what happens is there's decreased blood flow, meaning the tissue that's past this blockage is going to be ischemic. Okay, we want to know what tissue is going to be ischemic, which part of it, okay? So for example, if the occlusion is in the left main artery and he is left dominant, that means the LAD is not going to work, the circumflex is not working, nor is the PDA. So that means the entirety of the septum is going to be infarcted and there's going to be no blood supply. Does that make sense, everyone?
Yeah, that makes sense.
Do you guys have any questions? Okay. So this is very significant. Coronary dominance is one of the most important things in all of this review, basically. So to move on to the venous supply, essentially just follows the arteries. It's very simple, okay? So can anyone tell me what this right here, this structure that I just labeled is? Does anyone know?
Is this not called the Great Vein?
This is
the coronary sinus.
okay. Essentially, what happens is you're right. The great cardiac vein is right here. This is the great cardiac vein. Okay, it drains into what this structure is. This is the coronary sulcus. Okay, this is the coronary sulcus or the what we call the coronary sinus. Okay, the coronary sinus. So all the veins of the heart will drain into this structure, the coronary sinus, and will go into the right atrium. Okay, we'll show you exactly how that happens. Okay. So essentially, this is going to be the great cardiac vein, which runs along with the LAD. So the LAD, it runs with the great cardiac vein, okay? The great cardiac vein right there. The middle cardiac vein, it runs along with the PDA. The PDA or the PIA, it runs with the middle cardiac vein, okay? Small cardiac vein accompanies what? The circumflex, the left circumflex. And then right here, the small cardiac vein also accompanies the marginal artery, okay? And again, these all drain into one coronary sinus, which is inside the sulcus. That's what I meant to say. And it drains into the right atrium. So this is actually the right atrium right here. So I know this is the posterior side of the heart, but this is the IVC, and this is the SVC. And essentially right here is where it drains. Maybe I should just delete his so you guys can see. Erase all link. Yeah, so basically you can see right here, the coronary sinus drains into the right atrium. Is that very clear for everyone to see? Is that clear?
Yes, that's clear.
Okay, perfect.
Can I ask what the small cardiac vein accompanies?
Okay, the small cardiac vein accompanies basically both the right marginal. Okay, so no, these are actually this is the anterior veins of the right ventricle. Essentially, it accompanies the left circumflex. You know, this left circumflex artery?
Yeah.
That's what it follows right there.
Perfect, thank you.
Okay, now moving on to the anatomy of the right atrium. Okay, so essentially we're going to cover all of these right here, these structures. So the interatrial septum, the pectinate muscle, auricle, fossa valis, crista terminalis. We're going to go through all this right now. Okay, so to begin, this right here, this structure we can see is going to be the interatrial septum. So this right here, this whole thing that we're looking at is essentially dividing what is dividing the right atrium from the left atrium. So essentially, it's dividing the right atrium from the left atrium. And here we can see what we have. If we open up the right atrium, we have over here we call pectinate muscles. So this is the tough part of the right atrium, and this is very important for subhanal khaliq, for allow the right atrium to contract forcefully to give blood to the right ventricle. So this is very important. And then you have what we call the terminal crest, or the crista terminalis. This is attached to the pectinate muscles. You can see also right here, the crista terminalis. Essentially, it's the dividing area between the hard, the tough muscle, which is the pectinate muscle, and the smooth area of the right atrium. And we can see here the fossa ovalis. So this is a remnant of the neonatal period. So when you're in the uterus, you have essentially what we call a patent or a foramen ovale. So essentially, it's an opening between the right atrium and the left atrium to allow your brain and your body to get oxygen as a baby, because your lungs are not working. But once you're born, and once you have, after delivery, this closes up, because now the lungs are working and they're doing the job of getting the oxygenation. So you do not need this crossing of the blood. So that's what we have. That's the fossa ovalis, essentially. And as we said before, remember how we said the coronary sinus drains into the right atrium? This is right here, the coronary sinus. Okay. And this is, of course, the SA node. It's right near the SVC. This right here is what we call the right auricle. Okay, this is right here, the right auricle. And that's pretty much it for the right atrium. Yeah. So moving on to the right ventricle. So to start off, let's talk about the easy structures initially. So this is the right atrium. What valve are we looking at over here?
This is the tricuspid.
What structure is over here, Taib? If this is supposed to be tricuspid, what structure is this one right here that I'm pointing at? This is the aorta. What's this going to be? Right beside the aorta.
That's the pulmonary artery.
Perfect. This is the pulmonary artery, the pulmonary trunk. So what valve is going to drain into the pulmonary trunk? What do you think? The tricuspid or something else? So this is going to be the pulmonic valve. Okay, this is the pulmonic valve. Okay. So this is going to be drained into, this is going to go to the pulmonary trunk. This right here, this valve over here, this is the tricuspid. So the right atrium is going to drain into the right ventricle through the tricuspid valve, which is in turn going to send all that blood through the pulmonic valve all the way into the pulmonary trunk. Is that clear?
That's clear, yeah.
Okay, perfect. Okay. So essentially, this is, again, is the tricuspid valve. So it's called tricuspid for a reason. Why is it called tricuspid?
Because there's 3 cusps.
Yes, there's 3 essentially cusps or leaflets. Okay. So each leaflet has what we call a papillary muscle. Okay. So this is 1 papillary muscle. Okay. 2 papillary muscle and 3. Okay. So this is what we call the septum, the septal jisma, leaflet, or the papillary muscle, sorry. And it's attached to the septum, essentially. This is what we call the anterior superior leaflet, okay, because it's anterior. And this is what we call the inferior leaflet because it's inferior. The inferior papillary muscle. So these are all papillary muscles. So these papillary muscles, essentially what they do is they contract, pulling on these cords. So these cords are called coronary tendinae. So what they do is they help allow the muscle, when it contracts, to pull the valve and make sure it's fully closed. All right. And then you have the 3 cusps. So these are the 3 leaflets. So you have the anterior superior leaflet, you have the inferior leaflet, and you have the septal leaflet, essentially. So these are the three cusps of the three leaflets of the tricuspid valve. All right. And then you have, obviously, this is what we call, this is the moderator band. Okay. This is a piece of muscle in the right ventricle. And then again, we said this is the pulmonic valve, of course. And this right here is the rough muscular area of the right ventricle. It has a special name as well, and it's called the trabeculae carneae. Okay. So again, this is to help allow the right ventricle to contract forcefully and give enough blood towards the pulmonary trunk and to the pulmonary arteries. And by all means, if anyone has a question, please don't hesitate to stop me, essentially unmute yourself or anything, or write in the chat, and inshallah, I'll cover those questions. Essentially, the left ventricle anatomy. Okay, we're going to go over the left ventricle. Okay. So we're going to go over the anterior papillary muscle, the posterior, the coronary tendinae, the left atrial appendage, the aortic valve, and the mitral valve. Okay. So the mitral valve has how much leaflets, guys?
Has two.
Has two. So how much muscles will it have?
It'll have two, but they separate into four muscles.
Yeah, correct. Yeah, but there are two bundles, you could say, right? Yeah. So essentially, you're going to have what we call the anterior leaflet and the posterior leaflet of the mitral valve. Okay, and they connect to the muscles of the anterior and posterior papillary muscles. Okay, and this right here is going to be the left atrial appendage. Okay, very obvious structure. And then over here is very deep, but you can't really see. Is going to be the aortic valve. Okay, and essentially this is the trabecular. This is essentially the coronary tendon, as we said. And this right here, this muscular area, is again the trabecular carneae of the left ventricle. Okay. Now we're going to talk about the openings and the orifices of the heart. Okay. So superiorly, okay, the superior vena cava is going to essentially drain into the right atrium, of course. Okay, I was supposed to ask that question. The aorta essentially comes from the left ventricle. The left ventricle drains into the aorta. So what structure is going to essentially give blood to the pulmonary trunk?
The right ventricle. Right
ventricle, correct. Inferior, yeah, these are simple questions, so I'm sorry for didn't go over them. But the inferior vena cava will drain into what? What structure?
Right atrium.
Right atrium, correct. And posteriorly, oh, there's another posterior structure, something that drains into the right atrium. What do you guys think that is?
It was the coronary sinus.
MashaAllah, very good. That's the coronary sinus. It drains into the right atrium. Perfect. Okay. So now, the semilunar valves. Okay, this is essentially what we call the semilunar or the aortic and the pulmonary valve. Okay, so these are called AV valves, which is the mitral, the tricuspid and the mitral valve. So they're called AV valves because they're between the atria and the ventricles. And these are called semilunar valves. Okay. So the semilunar valves, okay, they're of course aortic and the pulmonary. So one of them has an anterior cusp and one of them has a posterior cusp. Can anyone tell me which one is which? So they both have right and left cusps. Okay.
I think the one with the anterior cusp is the pulmonary trunk.
MashaAllah, very good. Okay, so for me, how do I remember it? It's just the position of the pulmonary trunk and the aorta. So the pulmonary trunk is anterior in relation to the aorta, so it has an anterior cusp. The aorta is posterior, it's behind the pulmonary trunk, therefore it has a posterior cusp. Okay, very easy to remember, inshallah. And of course, they both have right and left cusps. And if you guys can see here in the aorta, that's where the right and left coronary artery will essentially get their blood supply from these cusps. Now moving on to the diaphragm. Okay, the diaphragm consists of 4 parts, all right? Essentially, there's a sternal attachment, so it's attached to the sternum, okay, at the in the anterior portion, and then it's attached to the vertebra, okay, so it's attached all the way back to the vertebra, okay, and then it has a costal attachment, which is essentially attaching to the ribs, and then it has a central tendon, all right, and it has 3 major openings. The first one is at T8. We're going to cover all this, inshallah, which is the vena cava opening, the aortic hiatus, which is going to be at the T10 level, and then have the esophagus, or sorry, the T12 level, and then the esophagus at T10. Okay, we're going to cover all this, inshallah. So at T8, okay, we're going to have a structure. This is right here. T8 is going to be where the IVC, or the inferior vena cava, goes in. All right. At level T10 is going to be the esophagus. All right. And then at T12 is the aorta. And of course, they're accompanied by something each. So the vena cava is going to be accompanied by the right phrenic nerve, which supplies the nerve supply to the diaphragm itself. And the esophagus at T10 is accompanied by the vagus nerve and the esophageal branches of the left gastric artery. Okay, which makes sense because the esophagus is going through here. Therefore, it's going to get branches of the arteries that apply to the supply the esophagus, which makes sense why it goes through the hiatus. And the aorta comes through at the level of T12, and it's accompanied by the azygous vein and the thoracic duct. Okay, so one question is it's a simple question I'm going to ask. What is the diaphragm? Is it made out of muscle or membrane? It's a simple question, I know, but just can someone answer that?
It's made out of muscle.
Of course, yeah, it's made out of muscle, of course. So are these openings made out of muscle or made out of membrane? It should be muscle, right? Because that's the whole thing is muscle, correct? Or is that incorrect? Okay, so essentially, okay, good. So essentially, if you guys can see this white part. This white part is membrane. So the rest is all muscle. That's muscle. So if you guys can see clearly, let me just erase this for you guys. Okay. So the esophagus opening and the aortic opening, it looks like muscle, right? Is that clear for everyone to see? It looks like muscular area. صح? Can you guys see that? Is that clear?
Yeah, we can see. It's clear.
Yeah. And the IVC opening, is it covered by white structure or muscular?
It's membranous.
Membranous. Like why is the IVC specifically covered by membranous? SubhanAllah.
Because the vein isn't going to be as thick as the artery or the esophagus.
Very good, mashallah. Another point is that it's low pressure. Okay. So the venous side has low pressure and it's going upwards. So the IVC is draining blood upwards towards the right ventricle. It's going against gravity. So imagine if it was surrounded by muscle, and every time you breathe and your muscle contracted, your diaphragm, you close your IVC. That means no blood is going to go to the right atrium. So if that happened, essentially, this is going to close off and you can't have any blood flow towards the right atrium. Okay? So that's why this is made out of membrane and not muscle. So that's a good and important tip. So moving on to the echocardiogram. All right. So there's 2 types of views. I talked about this before. The transesophageal, essentially they take a tube and they put in your esophagus, okay? And they have the camera and that shines towards the heart from the posterior side. Or you can just do it on the chest of the patient and it's looking downwards towards the heart, okay? This is looking upwards, this is looking downwards. So what's going to be the first structure you're going to see here in the transthoracic, and what's the first structure you're going to see in the transesophageal? Can someone answer that for me?
Transesophageal is going to be, I think, right atrium.
close, almost, mashallah, is going to be the left atrium. Left atrium, okay? And for the transthoracic, what's going to be the most anterior structure you're going to see?
Right.
The right ventricle, right?
Oh,
Okay.
right.
Yeah, the right ventricle. Remember, that's the most anterior structure of the heart, and that's giving you essentially the anterior border of the heart. So essentially, that's going to be the first thing you're going to see if you're going to put the echo on top of the chest of the patient. Does that make sense?
Yeah, that makes sense.
Okay. So now, just looking at this view, okay, if I told you this is the camera and I'm looking towards this way, what's the view of this? Is this going to be a transthoracic or essentially esophageal? Which one is going to be? If I'm looking from this side, if I'm looking towards this side, essentially, are these the atrium or the ventricles? Can you guys tell me?
These are the atria.
Okay, so if I'm looking at the atria, am I in the esophagus or am I on the chest?
You're in the esophagus.
Exactly. So a transesophageal is going to look upwards like this. A transthoracic is going to look downwards like this. Okay? Tamam. Okay. So, 1 second. So again, so A is going to be the right atrium. B is going to be the right ventricle. C is going to be the left ventricle, and D is the left atrium. This is the most posterior structure, of course. Okay, and of course the valves are essentially between the atrium and the ventricles, inshallah. Now, another important point is that in mitral valve stenosis, okay, the mitral valve is going to essentially be very rough. Okay. Essentially what happens is, does this lead to left atrial hypertrophy or dilation?
We get dilation.
Why is that?
Because the blood is going to pull back. It's not going to drain properly.
Yes, mashallah, very good. Mashallah, like the person who's always unmuting. Mashallah, very good answers. So essentially, yes. So because the valve is essentially, let me just do this right now. The mitral valve is going to be very stenosis. It's not going to allow blood flow to go. The left atrium is going to become very enlarged because all the blood is going to pull back instead of draining into the left ventricle. Okay? That's essentially what's happening. Okay, now moving on to the mediastinum. Okay? So the mediastinum is divided into two parts. The superior, which is going to be above the T2 level, and inferior, okay, this is below T2, all right? So superior is going to be, we'll talk about superior first. So the superior mediastinum is from the thoracic aperture, which is essentially the second intercostal space, or the T4 vertebra, all the way upwards. And it has veins, which is going to be the left and right brachiocephalic vein, which makes up the SVC. This is supposed to be SVC, sorry. The SVC. And the left brachiocephalic comes at an angle. Okay, this is very significant. So this angle is only important when we look at the cross sections, inshallah. Okay, you're gonna see why it's important to know why this comes at an angle, because it's gonna look more oval shaped. Okay. The arch of aorta is also in the superior mediastinum, and the three main branches. Okay, which is the brachiocephalic, the left common carotid, and the left subclavian. And behind these structures is a trachea, and of course behind that is the esophagus. So the esophagus is maybe the most posterior structure whenever you look at any cross section. All right. So look in here. All right. Let me just try to erase this for you guys. Okay, sorry. So essentially the trachea, guys, is going to be behind the heart. Sorry for the messy area. The branch point is going to be the T4 carina, or it's called the carina. Essentially, this is the end point of the trachea where it divides into two. So essentially what happens is if you see the one tube, you're at T4 or you're above. If you do not see the trachea, you are below T4 for sure. Why? Because the branching point is at T4. So if we see one tube, we're T4 above. If we don't see a tube, we only see two, or we see something else, it's going to be below T4. All right. The vagus nerve, it just wraps around the arch of aorta and it gives off the branch, essentially. And we can see here a little bit, I think we're going to make it clear in the next one, essentially what's going on. So again, the mediastinum continued is just basically it's showing you what's going on. So this is the right atrium, this is the SVC, this is the IVC, this is the right atrium, this is the vagus nerve, which is going to give off the left recurrent laryngeal nerve. Is going to wrap around, and essentially this is the aorta, which gives off the three major vessels, which is going to be the brachiocephalic, the left brachiocephalic, which divides into a left common carotid, a left subclavian, okay, and then the second branch is going to be the left common carotid from the aorta, and then the left subclavian is going to be the other branch. All right. Now, let me try to erase this for you guys. I don't know how to erase this. Okay, I'm sorry for that, guys. But essentially, we'll move on to the inferior mediastinum. Okay, so this is more significant and has more structures, to be honest, than the superior mediastinum. So anything above the second intercostal space is superior mediastinum. Anything below is going to be what we call inferior mediastinum. It's divided into three areas: posterior, middle mediastinum, and anterior. So the anterior mediastinum is any structure that's in front of the heart and behind the sternum. Okay, so it's very minimal. There's not really much things. Basically, only the thymus, which is actually only present in pediatrics, and is not present in adults, or is very minimal adults, and the mediastinal branches of the internal thoracic vessels. So the mini branches, the small branches that are going to supply the costal, essentially the ribs, so all the intercostal vessels, that's what's going to be in the anterior mediastinum. So not much going on there. The middle mediastinum is the heart and the great vessels and some other nerves like the recurrent laryngeal nerve, vagus, etc., or the vagus in the posterior, or the recurrent laryngeal nerve, for example. The posterior mediastinum is anything behind the heart and before the vertebra. So this includes the major structures such as the esophagus, so the esophagus, the descending aorta, you guys can see right here. This is the descending aorta. Okay, the vagus nerve. Okay, the trachea, of course, the trachea is going to essentially be right here, and it's going to divide into two. Of course, you're going to see that in a minute. And that's pretty much it for the posterior. So now, guys, we're going to go on to the cross section. Okay, the cross section, and I want you guys to be very active with this one. So then, inshallah, you guys can learn better. This is how you can get them right in the OSCE, inshallah, or the OSPE. So essentially, the first thing I want you guys to do whenever you look at a cross section is to orient yourself. Okay, so how do you orient yourself? Okay, it's basically you want to know what's anterior and what is posterior. All right. So when I look at this patient, what structures can I identify? First things first, I think very easy for everyone is identify the lungs. Okay, that's the easiest thing for I think all med students to see is the lungs. It's a very easy structure to identify, alhamdulillah. And then what I do is I look for the bones. Okay, I see right here the sternum. I know the sternum is at the front of the chest. It is the anterior part. So now I know this is the anterior part. I look back here. I can see the spinal cord. I can see this big nerve. And I can see the vertebra. This is the vertebral body. Okay, this is how it looks like. That's the vertebra. Maybe that's clear. That is the vertebra, and that's the nerve. That's the spinal cord, sorry. So now I know this is posterior. All right. Is everyone clear on how to orient themselves?
Yes, that's
looking
good.
at the cross section. Perfect. Okay. And then next, what I like to do is immediately after, I look for the most posterior structure. So right after this body, the vertebral body, the vertebra, I look for this structure right here. Can anyone tell me what the structure is? The small structure?
Is it going to be the esophagus?
Perfect. Why do you say it's esophagus?
Because it's the most posterior structure.
MashaAllah. Very, very good. MashaAllah. Very good answers, MashaAllah. Again, the most posterior structure, as we can see, is always going to be the esophagus. So this is a very good reference point for you guys to know, all right? Because if you look at all of this right now, it looks like a mess. Or maybe I can't identify immediately. So I take it step at a time, and it'll be very easy, inshallah. So first things first is orient yourself. What's posterior? What is anterior? And then look for the esophagus. Okay? Now I know the esophagus is where it is and all that stuff. And then I look for the major structures that help me identify what level I'm at, essentially, or what am I looking at. So what is this structure right here? This big structure I can notice right here. G.
Is this the opening of the pulmonary artery?
What makes you say that?
Because it looks somewhat anterior and it's bigger than the orifice that's to the left of it.
Okay, you just said something very important. So it's to the right of the vessel beside it, right? So this is the right and this is the left, صح? So you just said that, right? So this is the right side, this is the left side, correct? Okay. So this is another orientation. Always remember, it's always opposite. Cross sections are always opposite. So the left side of what you're looking at is the right side, and the right side of what you're looking at is the opposite. So it's just opposite. So this is gonna be the right side of the chest. This is the left side. So if this is the right side and this is the left, this structure is to the right of it. So is the pulmonary trunk to the left or the right of the aorta? If you can remember before.
The pulmonary trunk is right of the aorta.
It's to the left, right here. So this is the left side. This is the aorta. It's on the right side. All right. This is over here. Let's just make a better drawing. So this is going to be the heart. Okay. This right here is the pulmonary trunk. So this is right here is the aorta. The aorta is on the right side. This is on the left side. Does that make sense?
Yeah, that makes sense.
Khalas? So now you have your orientation in your head. Okay. So now if I go back here, this is the right side, this is the left side. What is this structure? On the right.
That's going to be the aorta.
Amazing, mashallah. Okay, that's going to be the aorta. Is this going to be the ascending or descending? What do you think?
I think it's the ascending.
Okay. So I haven't covered this yet, but why do you think it's the ascending and not the descending? I'll give you a hint. The descending is in this picture as well. But why do you not think?
Yeah, descending is H, I think.
Sorry?
Because the descending aorta is going to be H in this picture.
And that's not going to be the exact one it is, but essentially the reason why is because essentially when we look at the aorta, okay, what happens is this is a very good demonstration. The heart is in the middle mediastinum, correct? Is that clear?
Yeah, that's clear.
صح? And this is the aorta. Does that make sense? Can you see the aorta?
Yeah, we can see.
Okay, this is the one I'm pointing at. Is this ascending or descending?
This is ascending.
It's going up, صح? Okay. So, is this anterior or is this posterior?
This is anterior.
Yes, because the heart is going to be very anterior. It's not going to be at the back. صح? The heart is going to be a more anterior type of structure. Okay, so the heart is much more anterior to the esophagus and everything. So the aorta is going to come out from the heart. The heart is anterior. So the ascending aorta is going to be always anterior. Okay, and then it goes backwards. This is the arch. It goes posterior. صح ولا؟
صح.
So it's going posterior, and we have the posterior. What's this? This is the descending aorta. صحيح?
صحيح.
We talked about this before. Okay, perfect, mashallah. So if the descending aorta is posterior, okay, that means this can never be the descending aorta, صح? It can never be it, because this is right beside the sternum, right? So if this is the ascending aorta, it goes all the way back like this. I'm showing you like a horizontal view, and it comes and it descends right over here. That's where it goes. Is that very clear? Is that clear?
That's very clear.
Okay, mashallah. Very good. Okay, so now we covered the aorta. So I want you guys, what's very important is to have kind of like a 3D model in your brain, almost, of what the structures are. So I can know what am I looking at, because sometimes it's very confusing. And, you know, I've been through this as well. And if you look at something without orienting yourself, what's anterior, what is posterior, am I right, am I left, what am I looking at, what's big, what's small, you know what I mean? If you're not oriented, you'll be very lost. But very important is to orient yourself and know what you're looking at. Okay, so now after we covered the aorta, okay, so we can see the anterior big one is going to be the ascending, and it goes back, okay, and it descends as D. That's where it descends. All right, so this G structure is ascending, and this D structure is going to be the descending aorta. All right, now what's going to be F? Like, if we said this is the aorta, what's going to be F?
I think F is going to be the pulmonary artery because it's left of the aorta.
MashaAllah, excellent. See, MashaAllah, when you go logical, you'll never get anything wrong, inshallah. Okay, so again, we said this is the aorta, it's ascending, it's very big, and we can see it, and it's on the right side. The left side is going to be the pulmonary trunk, very obvious. And now we can see the pulmonary trunk is giving what? 2 branches, right? So these are going to be the right pulmonary artery and the left pulmonary artery. So now you have fully oriented yourself with the whole image now. Now you know essentially the entire image. You know, this is the aorta, this is the esophagus, you know, this is the descending aorta, you know, this is the pulmonary trunk that's dividing into the right and left pulmonary artery. Khalas, everything is good. Now, the other little key points is that you have 2 tubes here, okay? Is this posterior or anterior?
This is posterior.
Okay, so what structures in your brain are you thinking are posterior that have tubes? Something that the trachea divides into. What do you think that is?
Are these bronchi?
Yes. See? So it's good to orient yourself. What's posterior? So the posterior, I don't see a trachea. I don't see 1 tube. Okay, I don't see a tube right beside the esophagus. I see 2 tubes. So now I know I'm looking at the bronchi. Okay? I'm looking at the right main bronchus and the left main bronchus. Okay? Khalas? And lastly but not least, H is going to be always a difficult structure to identify. I'll be honest with you guys. It's going to be the most annoying one, maybe just because of orientation. But I want you guys to understand, is the H, is it on the right side or left side?
It's on the right side.
Sahih. Okay. So what structure is going to be, okay, if this is let's for example, I'll orient yourselves right this. If this is the aorta we're looking at right here, and this is the pulmonary trunk, okay? So this is the right, that's the left. What structure is going to be a tubal structure that's going to be onto the right of the aorta? What's going to be to the right of it?
Superior vena cava.
Vena cava is right, but which one do you think?
Well, maybe this is inferior.
Inferior or superior?
I think actually this one is the superior because G is going to be the aortic arc, which is superior.
Mashallah. See, look at the logic, mashallah. Very good. The aorta is superior. We know that. If you remember from the superior mediastinum, the aorta goes all the way up there. So now we know that we're superior. We are not in the inferior area. So this is definitely, for sure, the superior vena cava. The inferior vena cava, we will not, if we were to see the IVC, we would definitely not see the aorta or the pulmonary trunk at all. All right? Now, moving on.
Can you go back to the last slide? I just have a question.
Absolutely, sure. Feel free to ask.
What is structure B?
Did I cover B? Sorry, I didn't cover it. Okay,
I don't know if.
Sorry. I don't think I covered it. Okay, so B, this is a special structure as well. Okay, it's a very small structure, very, very small. This is the azygous vein. Okay, so the azygous vein, we're going to see in the future slides, is going to go like this. It's going to have a branch, and it's going to all the way drain into what? The SVC. This is the SVC, صح? So they're going to see the azygous vein, you're going to see it drain into here. is going to be more obvious when we look at the previous images, okay? And again, is this posterior or anterior?
This is posterior.
Okay, and we know for a fact that azygos is where?
Azygos is posterior.
Sahih, right? Okay, perfect. So again, whenever you orient yourself, am I posterior, am I anterior, it's going to help you identify what the structure is. All right?
All right, I have another question, if that's okay.
Sure. No, absolutely. The whole point is you guys asking questions, and inshallah you'll.
There's a cavity by structure B. Is that one of the sinuses?
This is just the lungs. This is part of the lungs.
Oh, okay.
The black area. Okay, this guy's a smoker, basically. This guy's a very bad lungs. It's just black lungs right here.
Oh, okay. That
You
wasn't
see-
very clear from the image.
Yeah, you see how it's light from here, it's black here. This is smoker lungs, horrible lungs. So guys, definitely don't smoke, please. Don't smoke. Yeah, so that's just the smoker lungs. There's nothing significant about that.
Perfect, thank you.
You're welcome. Yes, okay. So someone said, I don't know who MA is, what the name is, but someone said, so we're under T4. Amazing question, mashallah. Okay, so we said, if you see one tube, which is the trachea, you're what level are you at minimum? You're at T4, صح? T4 and what? Above or below? If I see one tube. If I see one tube, I'm going to be T4 or above. Sahih, mashallah. طيب, if I don't see the trachea, am I above T4 or below it? I'm going to be below it. If I don't see the trachea, I am below T4. Because remember, the trachea essentially divides. The trachea divides. So this is the trachea, okay? This is the trachea. And this is the carina. I'm going to label it as C. It divides into the left and right main bronchus, okay? Okay, please, if everyone can be with me for a little bit so you guys can understand this very key point. Maybe it wasn't clear before. And guys, if anything is not clear, please let me go over it again, okay? So essentially, this is the trachea, okay? And this is the carina. The carina is at level T4, okay? Does that make sense? So this is level T4. So if anything below this is going to be less than T4, anything above is going to be above T4. So what does that mean? If I see the trachea, I have to be above T4 because the carina divides at T4. So if I see it, I'm definitely above, for sure. At least at or above. But if I don't see the carina, if I don't see the trachea, and I see two tubes, that means I'm below T4. Is that clear for everyone?
Yeah, that's cool.
Okay. So do I see the trachea or two tubes here? What do I see?
We see two tubes.
So what level am I? Am I above T4 or below?
No, we're below T4.
MashaAllah. Very good. Very good. So I am definitely below T4 here. Whether that's T5 or T6, we'll cover that later, inshallah. But the most important thing is identifying, am I at T4 or below or above? That's the most important thing I want you guys to know right now. So we're definitely below T4. Okay. So these are other just images just to see the reference point in the cadavers, for example. So we can see these are cut off. Basically, this is the aorta and the pulmonary trunk. Okay. This is the SVC and the aorta. So sorry about that. That's the aorta. That's the SVC. So what we can see here, this is the azygos vein. So remember how it's posterior? Look at how it's posterior and it drains into the SVC. This is the SVC right here. Is that clear?
Yeah, that's clear.
See? So now when I go back to this image and I can tell you this is the azygos vein and it goes like this to the SVC, it makes sense now, right?
Yeah.
Okay, perfect. So now you guys can see that again. Azygos vein, it goes posteriorly, superior, and it drains into the superior vena cava. All right. And then you can, of course, see other things such as, for example, the thoracic sympathetic trunk. Okay. This is this is the intercostal bundle, otherwise called VAN, because it starts with a vein, artery, and nerve. Okay, nothing much except to like memorize this. Nothing else. This is the thoracic descending aorta, so this is going down. This is the thoracic duct. You can see it's also posterior structure. Diaphragm. Yeah, nothing really much. Salah. Okay, so now we'll begin.
If you could go back,
Sure.
somebody in the chat.
Somebody said something. How to differentiate between phrenic and vagus on a cadaver. Okay. So essentially, what happens is the phrenic nerve is going to be more lateral. So you'll see here, this is the left vagus nerve. It's right beside, very close to the aorta. The best reference, the best reference would be to see the recurrent laryngeal nerve. So the one that's close to the aorta and is giving off that branch, you can tell that's the vagus nerve. More laterally is going to be the phrenic. Okay, it's going to be much more lateral. Okay, does that make sense?
Yeah, that makes sense.
Okay. Tamam. Okay. Bismillah. So now we're gonna go to the rest of the cross sectionals. Okay. So this is the reference point. So this is the reference point. This is what we're looking at. Okay. So what do I expect to see in this image? This cross section. I want to see what the right brachiocephalic vein. What's this vein right here?
This is the left brachiocephalic.
Okay. Can you guys see how this is coming at a much more acute angle than this one?
Yeah.
Salah? So when you look at it, if I cut a cross section right now, if I cut it in half, this one's going to look more like a tube. So for example, if I have a structure like this that's going straight and I cut it in half, what's going to look like? It's going to look like a tube. Salah? It's going to look like this. If a structure is going like this and I cut it in half, it's going to look like what? It's going to look like this. It's going to look like the same. It's not going to look like a tube. Okay? It's going to look like something that's coming at an angle. That's what it's going to look like. All right? Is that clear?
That's clear, yes.
Do you guys like these drawings or you just want me to explain it?
No, the drawings are helpful.
Okay, perfect. Now, basically, okay, we're going to look again, always identify where am I. So can someone kind of just walk me through this just a little bit? At least orient me. Where am I looking at? What's right? What's left? Anterior, posterior? How would you go about this one?
Okay, so we can see the spinal cord really. It's very obvious in the spinal segment, so that's going to be posterior.
Perfect.
The left side of the image is going to be right.
Yeah.
And then the right side of the image is going to be left.
Yes.
And then opposite to the spinal cord is going to be anterior.
Perfect. Okay.
And I think at this level, we're above T4 because there's one big tube.
Yes. Which one is that?
That's going to be the trachea.
Yes. It's this one, Salah?
Yeah, because it has a C-shaped ligament.
What's this one right here behind it?
This is the esophagus.
Why?
Because it's posterior to the trachea always.
Yes, it's the most posterior structure, always. So now you know you're, mashallah, very good. I didn't even ask you for that. But now you know you're above T4. Perfect, mashallah. Okay? You are above T4 for a fact. Now moving on. So now you identified this is trachea. So this is the esophagus. What's these three structures? What do you guys think? It's not easy, but sure, we can go through that. What do you guys think it is? Actually, before you do that, okay? This structure right here is on the right or left?
It's on the right. Right.
Okay. And what did we say is a major vessel that's coming on the right side and is superior? So this is going to be above T4. Is that superior or inferior?
This is superior.
Superior. So what structure?
Hold on, would this be the right brachiocephalic and the one on the one right to it, or the one left to it, the left brachiocephalic?
Excellent, mashallah, excellent, mashallah, very good. And we said right here, look how this one is a tube and this one's coming like this. Why? Because we said before, this one's coming more acute, this one's coming at an angle. That's why when it's cut in half, this one comes as a tube and this one's going to come like this. All right? You see how it looks? Now it's very obvious. صح?
Yeah.
Okay, so this is going to be what? Right brachiocephalic. And this is the left brachiocephalic. You see how it's coming at an angle? Perfect. So now this is the trachea again, as you said, and this is the esophagus. So what are these three structures? I'm seeing three structures. What do you think it is?
Are these arteries?
They are arteries. What kind of arteries are you going to be seeing in the mediastinum, though? If it's not the aorta, what arteries are you going to see? Is this the aorta? Is any of them the aorta? What do you guys think?
No, none of them are the aorta.
Okay, صح. So you have three arteries that are not the aorta. What else could they be?
Hold on. This could be the right. I will say it would be the right subclavian, then left common carotid, then left subclavian.
MashaAllah. Which is all branches of what?
The arch.
Perfect. خلاص, amazing. So if you see three arteries, I don't see the aorta. So I look at this image and I'm like, I don't see any aorta and I don't see any pulmonary trunk. All I see is three vessels. Okay. So now I know for a fact that this is going to be the branches of the arch of aorta. And the three branches are the brachiocephalic, the left common carotid, and the left subclavian artery. Okay. So remember, the one vessel over here is the first branch. The first branch is what? The brachiocephalic. Okay. The brachiocephalic artery. There's only one brachiocephalic artery while there's two brachiocephalic veins. Does everyone understand that?
Yeah.
Okay. And then, of course, the right brachiocephalic divides into the right common carotid, the right subclavian. So the three branches are the brachiocephalic, the left common carotid, and the left subclavian. All right? Clear?
That's clear, yeah.
Yeah, خلاص, mashallah. And now we know, mashallah, from the person who's answering with us. Sorry, what's your name again?
Abdurrahman al-Dahash.
والنعم والله. Okay, so Abdurrahman is answered. He said it's above T4. MashaAllah, very good answer. Because we can see one tube, the one very big tube, which is the trachea. Now, again, this is the reference point. We can just see the names. So, of course, this is the right brachiocephalic vein and the left brachiocephalic vein. This is going to be the brachiocephalic trunk, left common carotid, left subclavian, trachea, and esophagus. Okay, and this is the same picture again with the three main vessels, three main branches of the arch of aorta, as well as the other structures. All right. Now, if we go down even more, okay, so look at this line. So what do I expect to see? I want to see the two lungs, of course, always. And I'm going to see what? I'm going to see the aorta superior vena cava. Sahih?
Sahih.
Okay, so that's what I expect to see. That's what I want to see. So when I look over here, I again orient myself always. You guys can see this is the spinal cord. So that's P, posterior. This is the sternum, anterior. This is always going to be the right. It's going to always be the left. It's always going to be switched. I look at the most posterior structure. That's going to be the esophagus, as you guys always answered. This, I see one tube, trachea. So what level am I? Above or below T4?
We're above T4.
Above T4. Okay. I see two structures as well. This is a very, very big structure. Wow, it looks like it's bending backwards. What do you guys think that is?
Is this going to be the aorta?
Yes. It's going to be what? The arch of aorta. All right? Makes sense?
Makes sense, yeah.
Yeah, because the aorta is supposed to come, the ascending aorta is over here, صح? It goes backwards like this. So now if I see only this left, I don't need to see the ascending aorta. I already know this is going to be the remaining part, the arch. Does that make sense?
Yeah, that makes sense.
Yeah. And then this is going to be the what? Essentially, this is going to be a confusing one. Okay. So I'm going to see two vessels here, actually, that they drain to each other. So if I gave you this by itself, this is the superior vena cava. So what's this structure right here? We saw in the previous image, but what structure is this?
Would this be the left subclavian?
Left.
Or no, left brachiocephalic.
Very good, mashallah. Very excellent. Remember, it's coming at an angle. Sah wala? Anytime I see an angle coming like this, going to this SVC, that's the left brachiocephalic vein. Tamam? Okay. And this is the other plane. This is essentially going to look at the carina. This is the carina where the trachea is going to get cut off. This is looking around T4. So I expect to see one tube, of course. I'm going to expect to see the aorta, the SVC, and other structures. Now, again, orient yourself always. That's the spinal cord posterior. This is sternum anterior, right and left. Halas? And then you look at the esophagus. That's number one. You look at trachea, number two. Now you move on. Halas? Now you see a big anterior structure. What's this one?
Aorta.
Which one?
Ascending.
Why?
Because it's anterior.
Because it's anterior. Amazing. And this one is going to be?
Descending aorta.
Descending aorta. Perfect. Okay, now. What is going to be to the right of the aorta? Which vein?
Superior vena cava.
Superior vena cava. Okay. So now it's having what? It's having some posterior drainage. What's draining into this? What is it exactly? What do you guys think?
Could this be the azygos?
Excellent, mashallah. Excellent. So the azygos is right here. Look at that tiny circle. I'm gonna put it like that. It's posterior, right? It's posterior. And the SVC is, of course, in the normal structure. It's going to be a more anterior. So as we said, I'm going to show you a previous image before, maybe you can see the previous image. Where was it? This one, yes, this one. The arch of the azygos vein, you guys can see, is posterior, okay, and the SVC is anterior, halas. And this is the arch of azygos. So the azygos is posterior, the arch is crossing, and the SVC is anterior. So now we go back to that image again. Okay, we'll go back to this image. What can we see? We can see the anterior SVC. We can see a small vessel right beside the esophagus, posteriorly to the azygos vein, and it drains into the SVC. That's how we know this is azygos. Is that clear?
Yeah, that's clear.
All right. Perfect. And this is T4, T5. Why do I say it's T4 to T5 and not above T4? That's a good question, actually. Why am I saying that? Why do they say right here? They write down that this is T4 to T5 and not T4. Does anyone know?
We can still see the trachea.
Exactly. We can still see the trachea, even though it's beginning to divide. So that means we're right below the carina, because the carina is a perfect circle. This is not a perfect circle. It's beginning to divide. So now I know I'm literally just below it, like right here. So for example, this is the trachea, and it's dividing here. Okay, let's say now. Let me make that. If it's dividing here, this is the carina. We are like literally right here. Is that clear? Does that make sense?
That's clear. Mm-hmm.
That's why I can see a little bit of the branching. I can see the little bit of the branching because it's giving me two separate tubes, but they're still connected. That's why it's still around T4. All right. Moving on. Okay. What is this image? Hold up. Okay, this image is okay, yeah, this image is good as well. So you guys have identified these structures before, of course. You identified the esophagus, descending aorta, the SVC. This right here is going to be what? What do you guys think? This posterior structure. Maybe it's a little more difficult. Okay. Does anyone know what this structure is, Tayyib?
Is this the... I'm not sure.
You're not sure. Okay,
But it goes
fine.
into the lung, so I think it's maybe the pulmonary artery.
Excellent, mashallah. So basically what happens is this might be a little bit more difficult, because remember how before we saw the pulmonary trunk, pulmonary artery, and we saw another branch here, صح? Right? And now we only see one branch. So it was a little bit more confusing. But the reason is because the pulmonary trunk, when it gives off, this is the aorta, let's say, this is the aorta, this is the pulmonary trunk. It gives off the right and left pulmonary artery at different levels. So you may see only one of them, not both. So you can still see the pulmonary. How do you know this, Lay? Because the ascending aorta is always the most identified structure. You can identify that very easily. And then you said to the left of it, remember this is how this is left, this is right, this is posterior, this is anterior. So if this structure is to the left of it, it has to be what? The pulmonary trunk. So the pulmonary trunk is going to definitely give off the pulmonary arteries going into the lungs. MashaAllah. Very good answer. Okay. Moving on. Yeah, maybe you guys also saw this before. This is the right main bronchus. This is the left main bronchus. Yeah. Otherwise, yeah, everything should be clear, inshallah. The next image we're going to be taking is now we are fully below the carina, completely below it. All right. So we should see what? We should see the two main bronchi. All right. And we should see the heart in general. Okay. Or the great vessels, sorry. So you guys saw this image before, so I don't think there's much needed to be said. We already covered this one. Can we go over this quickly? Can anyone tell me what this structure is?
This is with pulmonary artery.
Yeah, giving up the right and left pulmonary arteries. By the way, this is the pulmonary trunk. It's better to say it's the MPA, or the main pulmonary artery, but it's also called the pulmonary trunk. So you just have to be a little bit more clear about what you're saying. All right, Abdurrahman?
Gotcha.
Okay. This is the aorta. Okay. This is gonna be the descending aorta. Okay. These are the two main bronchi. Okay. Just a question, guys. This is maybe a important question. How did I know this is the descending aorta and not this one? They look very similar. Why is this one not the aorta and this one is?
Because the descending aorta is going to be posterior to the bronchi.
Yes, it's going to be posterior to the bronchi. Very good. Yeah, that's very important. Also, another simple thing is this: what? These two structures are parallel to each other. Very parallel. One is to the left, one is to the right, one's to the left. And there's no trachea. So I know these have to be what? The bronchi, correct?
Correct, yeah.
That's another way of looking at it, you could say. Yes. And then yeah, nothing else to identify, Sarah. That's good. Okay. Actually, one more structure, sorry. Does anyone know what this structure is right here? Okay, Farah. That's a very good answer. The azygous vein is going to be in that position. I'll show you where it is actually, but it's not the azygous vein.
I think this is part of the lung, isn't it?
This is the azygous vein right here, Farah. All right. This is another structure. To be honest, this is a posterior.
Oh, is this a lymph node?
No, it won't be a lymph node, to be honest. Essentially what happens is this is the azygous vein, correct? Okay, so this one right here is the SVC, this is superior vena cava. This is the anterior structure. This is the azygous vein. It's posterior. And this is another, essentially what? Someone said IVC, okay? That could be the answer. I'll actually, let me look for this. I'll have to check this one again, Sarah. I believe this is going to be, it has to either be the IVC or it can be it can be a different structure as an artery. The point is, I want you guys to ignore this one. This one's a little more difficult, a little more challenging. I'll get back to you guys on that one, inshallah. Moving on, we'll talk about how to identify structures on the X-ray and how to identify structures on the aortogram. Is it IVC? Yeah, it makes sense. It makes sense, صراحة. I agree with you. It does make sense that this is the IVC. Very correct. خلاص. If they said in the lab that it's IVC, go with that. Inshallah, you'll be good. So the main things I want to check is the cardiac shadow and the structures in the aortogram. All right. So the cardiac shadow is essentially, we don't see the heart essentially in the X-ray. Do we see the heart? We just see the shadow of it. So what does that mean? We see the borders of the heart. Okay, so we don't see the heart itself. We see the borders of it. So if you guys remember from the start of this lecture, we talked about the borders of the heart, صح? And what borders the lungs. So what is the right border over here that's touching the lungs? What structure should this be?
Oh, this is the right atrium.
Excellent, mashallah. This is going to be the right atrium. Okay. So the right atrium is going to be that little, I'll erase this. If you guys can see, you see that little extra indentation on the lungs? Is that clear?
Yeah, it's clear.
Yeah. And then you can see what? Another indentation that's going straight. What is this straight structure that's going into the right atrium?
That's going to be the superior vena cava.
Yes. And then you have another inferior structure. What's that going to be?
Inferior vena cava.
Excellent. Excellent. Okay. And this structure right here is going to be the left border of the heart. What's it going to be?
This is the left ventricle.
Left ventricle. Excellent, mashallah. And then we have what this is a little notch or a notch. What is it going to be? What makes this?
This is the aorta, the arc of aorta.
The arch of aorta. Excellent, mashallah, tabarakallah. And that's the main shadows or the main borders of the heart. So you know the arch of aorta, the LV, the right atrium, the SVC, the IVC. That's what makes the shadow. That's how you know what the shadow is. Now moving on. This is what we call a CT angiogram, or specifically a aortogram. Essentially, you inject dye inside the patient's vein, and you wait until it gets to the left ventricle. And once it pumps it into the aorta, you take a picture, take a snapshot. Take a snapshot and you see how the arteries are looking. So essentially, we're going to look at what's this branch right here.
This is
So first of all,
right.
yes.
Right brachiocephalic.
So I want you to correct one word. You said it correctly, but just redo the answer one more time. You said right brachiocephalic. Which is the correct word there? One of those words are not needed.
Oh, I don't need right.
Yes, why?
Because there's only one brachiocephalic.
Excellent, excellent. This is going to help you orient yourself so you don't get confused. Oh, is there a left one? No, there's only one brachiocephalic artery. There's only one. It's on the right side. That's correct. But there's only one of them, so I don't have to say it right. It's only one of them. Make sense?
Yeah, that makes sense.
Okay. And again, this is the ascending aorta. This is the arch. This is the descending aorta. This one's going to be what? Number 5.
The left common carotid.
And number 6?
Left subclavian.
Left subclavian. And of course, left subclavian goes on to do this. Goes to give the brachiocephalic gives on to the left common carotid, gives on the left subclavian, etc., etc. And then that's pretty much it. That's pretty much the most important stuff. I would go through the other branches as well, but it's a little too complex. Maybe you guys should cover them as well. But I don't think they'll bring inshallah from those branches. But definitely do cover them and review them. And then moving on, we did this before, Salah. We did this one more time. So let's just go over it again. So this is posterior, this is anterior. Okay. So this is not really clear, but I have the SVC over here, and I have 1, 2, 3 vessels. So what's going to be these 3 vessels?
12 is going to be brachiocephalic.
Yes.
And then 11 left common carotid, 10 left subclavian.
Excellent, mashallah. Excellent. Very good. Just as you said, that's exactly what should be there, inshallah. And now this is going to be what we call the trachea, essentially an image looking at the trachea. So this is number 1 is of course trachea. Number 3 is the right main bronchus. Number 2 is the left main. What's the difference between a clinical significance between the right and left main bronchus? Does anyone know?
The right main bronchus is oriented more laterally, so when things get stuck in the trachea, they usually go to the right bronchus.
Yes, because what is not lateral, it's more vertical.
Yeah, exactly.
Yeah, because what look at how vertical it is. It's almost just like the trachea, while the left main is more horizontal. So anything that's gonna come in here is gonna get stuck right in the right main bronchus because it's very vertical. Okay, that's a very important clinical significance. MashaAllah. All right. Moving on, we've already covered this image. Actually, we've already covered this one. This one's not really clear and it's not very good, so I think we should just not go over that one. But essentially what you guys want to do is that what's the most posterior part of the heart? So now we're looking at the heart. We're not looking at any vessels. So there's 4 chambers of the heart. I want you guys to identify them by circles, essentially. So always, what's posterior, what's anterior? It's going to make your life very easy. What's the most posterior structure of the heart?
The right atrium.
Are you sure?
Oh, left atrium, sorry.
Yes, left atrium. Yep, perfect. And the most anterior structure is going to be what?
The right ventricle.
Right ventricle, mashallah. Very good. So now I just attached the other ones. So the small one beside the RV is going to be what? The right atrium. The big chamber beside the left atrium is going to be what? The left ventricle. Khalas. Now I oriented myself perfectly. So if I ask you again, what's this structure over here?
This is the right ventricle.
What's this one right here?
Right atrium.
Why is the right atrium?
Because it's closest to the right ventricle.
Yeah, and it's not posterior, huh? Because the one most posterior is what?
It's the left atrium.
Perfect. And this is going to be what?
The left ventricle.
Clear?
Yeah, that's clear.
Okay. We covered the x-rays, huh? Okay. Yeah, pretty much nothing else. This is the cardiac shadow again. So look at that, the knob or the arch of aorta. So this is just a better image of mine. Nothing much to Salah to see. That's the LV making the border. That's the RA, right atrium making border. This is the SVC. And this is the IVC. Khalas, clear?
Yeah, that's clear.
Yeah. Very good. Again, is the same, is a different cardiac shadow. So this is going to be a lateral x-ray. Sometimes you take a lateral x-ray of the patient needed for anything, for example, any clinical significance, and you want to identify the structure of the heart. So you can see right here, this is the most anterior thing, is going to be the right ventricle. So most posterior is going to be the left atrium. In between is going to be what? Left ventricle. And then again, is going to be a far side is going to be right atrium. So you can easily orient yourself based off posterior and anterior. Make sense?
Yeah, that makes sense.
Hopefully that's clear. Yeah, I think nothing else Sarah to do for that. This is a CT scan above T4 again, as we said. Okay. Again, the key to CT scan is to know the level of not the aortic arch. What level? Level of what? What should
the trachea.
The trachea. Okay, the trachea is the most important key. That's how I know what level I'm at. Okay. So this is actually just, let me just cover this one more time. So anything above T4 is gonna have the trachea, صح? Exactly. So that's the most important thing. Anything above T4 will have the trachea, has to have the trachea. Anything below T4 has to have what? 2 tubes. Has to have what? The bronchi. Halas? And then you can see what? It can maybe be the heart. It can be the great vessels. But anything below T4 will not have what? The trachea. That's the most important thing you can see. And of course, aortogram, we can go over again. I think I just covered that. But we can go over the small branches as well. So after this, the subclavian, okay, you can have branch number 9. Okay, now branch number 9 is going to be the vertebral artery. It's going to go all the way to the vertebra, right here, those vertebra. Okay. Number 10 right here is going to be what we call the thyrocervical trunk. Okay, it's another branch of the subclavian artery. The 14 is going inferior. It's called the internal mammary artery. This is one of the arteries that's used for cardiac surgery. So essentially, the artery is going to be like this. What happens is that it's coming off the left subclavian. We harvest this artery and we attach it to the heart. So the heart is where? This is the aorta. So the heart is right here. This is the structure of the heart. So what happens is, let's say there's an LAD. This is much too advanced. Maybe this is for people who are interested. Essentially, what happens is the internal mammary artery is going to be harvested and is going to be attached to the LAD if there's any blockage. If there's a blockage here, I attach it here, and then it gets supplied directly from the subclavian and supplies the myocardium, subhanAllah. So that's just some interesting side knowledge. It's not very important, but that just helps you remember that internal mammary is going to be what? Going inferiorly. Okay. Number 13 over here is not identified, Sarah. Again, the most important things is the vertebral artery, the internal mammary, which is these ones. That's very important. The thyrocervical trunk, which is number 10, and then the left coronary artery. I don't think it's right. Oh, it is. The left coronary artery, and then the LAD, the LAD. So subhanAllah, maybe I can make this image much more clear. So this is the LAD according to number 17, correct? It says the anterior descending. And it says the circumflex is 18. But the orientation seems a little funny, don't you guys think?
Yeah.
Slah? Why? Because it's a 2D image for a 3D structure. Does that make sense? Yeah. So essentially, if I'm going to do what? If I'm going to do this, draw the heart. So if I draw the heart like this, okay, maybe it's not the most clear drawing ever, but this is the LAD. That's why 17, it looks like it's going horizontal, صح? If you look at it, it looks like it's going horizontal, right? But it's actually going in this fashion. It's supplying the myocardium like this, which is why it looks like it's completely horizontal. While the circumflex is going around like this. That's why it's coming at 18. Maybe the drawing isn't the best, but it's going around like this, and it comes down, and it supplies the PDA if in right dominant people. And that is why it looks like it's. That's why it looks like it's behind it. It's not even like near the LAD. Maybe we'll make that better in the future slide. Or I don't think we have another one. But essentially what happens is the LAD image is going to look like this. This is the LAD. Is going to be looking like it's horizontal. And the PDA is going to look like it's what? Coming also horizontal. All right? But then if you draw the image of the heart, it's going to make much more sense to you as to why it looks that way. Because again, it's a 2D image and a 3D structure. So the LAD is coming like this. If I was to erase this part, it's going to look horizontal. So let me just make this, let's just draw the heart first. If I draw the heart first. Okay, I draw the heart. And this is the interventricular sulcus. Khalas? This is the LAD. The LAD. Khalas? And this is going to be the what? The right coronary artery. Are you guys following me?
Yeah, we're following.
This is the PDA, Islah. And this is going to be what? The left circumflex is going around and posterior, right? Okay, I'm going to erase just this. I'm going to erase just this part. You see how different it looks now?
Yeah.
You see how confusing it can get?
Mm-hmm.
So now what you always have to keep in mind is the orientation of the 3D heart shape. So the PDA right now does not look like a PDA at all, Salah. There's no way I would think this is a PDA. It's coming in like at a weird angle. It's not going inferiorly. It doesn't look like it, right? It's looking like it's horizontal. And the LAD is not going anteriorly. It looks like it's just going horizontal. But actually, if you're to draw it out and picture it in your mind, it's going to be very clear, inshallah. Does that make sense, guys?
Yeah, that makes sense.
Okay, great. And of course, we covered the bronchogram. And I don't think there's anything else to cover, inshallah. All right, now I'm going to move on and give the reins to Faisal Alkhwaiter, and he's going to cover from here, inshallah. And remember, if you guys have any questions, feel free to always write them in the chat or to unmute yourselves, then we'll answer them, inshallah. And my phone number and email is at the end of the lecture that we're going to give you guys. So if you guys have any questions, please don't hesitate to give me a text or email me. Either works, inshallah. All right, Faisal, you can go ahead.
Thank you, Abdulaziz. Good evening, everyone. I hope you can see me. Before we start, does anyone want a 5-minute break so we can start fresh, or should we continue?
Let's take a break.
Okay, so it's 9:45. Let's start back at 9:50. Does that sound good?
Sounds good.
Thank you. So, assalamu alaikum wa rahmatullahi wa barakatuh. Hello, everyone. I'm Faisal Alkhwaiter. I'm a secondary medical student. Today we'll be continuing, inshallah, the OSPE review. We've covered, Abdulaziz, mashallah, covered a lot of things, the cardio part. Inshallah, we'll be covering some pulmonary anatomy, your pulmolab, and some histo. Inshallah, I'll be focusing on the histo because it's a pretty significant part of your OSPE and it's very high yield. So let's start with the sternum here. So the sternum is a 3-structured bone. So it's made of the manubrium, body, and xiphoid process. It provides 2 functions. One is the protection, and the other one is the attachment of the costal ribs. So let's start with the manubrium. So the manubrium has the jugular notch superiorly, and it articulates with the first rib and half of the second rib. And then you got a very important joint here. Can somebody tell me what is this joint, or what is its clinical significant famous name?
The angle of Louis.
Yes, it is the sternal angle or the angle of Louis. It's highly significant clinically because it provides the placement of which we can count the ribs. And then you got the body where we can count the ribs 3 through 6. And in the xiphoid, which is mainly cartilaginous, and it articulates with half of the 7th rib. So now let's go into the ribs. So the ribs are usually made up of 4 parts. So you got head, neck, tubercle, and body. By the way, if I'm speaking too fast or I'm not clear, please stop me. Please ask questions. I want this to be as interactive as possible. So starting with the head. So the head is usually wedge-shaped. So it has 2 articular facets. So they usually connect onto the vertebra in the back. So usually the superior facet. So we got 2 facets. The superior facets connects with one rib, with the one vertebra above the rib itself. So let me clear this up. We got rib number 5. So it has 2 facets. The superior facet would attach to T4, and the inferior one would attach to the correlation, the same number, so rib T5. And in the neck, there is no bone, there is nothing significant. And you got the tubercle, which provides the articulation surface with the transverse process of the vertebra, and it should be the same corresponding vertebra. So if you have the transverse process of the 5th rib, it should attach onto T5, and that is not there in ribs 11 and 12, and we'll explain that when we talk about the atypical ribs. And then the body is flattened, and we have a significant structure called the costal groove. Does anyone know what is the significance of this groove?
It houses the intercostal arteries, veins, and nerves.
Yes, the neurovascular bundle. So the intercostal vein, artery, and nerve. Thank you. And then you got our 5 atypical ribs, which are the 1st, 2nd, and 10 through 12. So we got 5 atypical ribs. We usually focus on the first one because it's very significant because it's a lot smaller than the other ribs, and it has only 1 facet, and it also has a groove for the subclavian vessels, which are the subclavian artery and vein. We also have different ribs, such as the 11th and 12th rib, which are formerly known as the floating ribs. Those are the ribs here. They do not attach to the sternum, and they only have attachment to the vertebra. So let's talk about true and false ribs. So we can classify ribs onto true, false, and you can if you classify, you can also classify 11th and 12th as floating ribs. So the 1 through 7 ribs are true ribs, which because they attach anteriorly with a cartilaginous costal cartilage, and then ribs 8 through 10 they merge together to make one costal cartilage connection point with the sternum. So now let's jump into the lung. So basically, the lung consists of an apex, which is the top part, the base, which is the inferior part, and then you got surfaces, borders, and lobes. So for the surfaces, it is usually what area of the thorax does it face. So we have 3 surfaces. Does anybody know what are the surfaces?
Anterior, posterior, and lateral.
We can call them also in relation with what they are facing. So we can call them costal, mediastinal, and diaphragmatic. So they're usually and then for the borders we call them anterior, posterior, and inferior. For the lobes, we have 2 and 3 lobes. Usually, with the right lung, you got 3 lobes separated by 2 fissures: the transverse fissure and the oblique fissure, and then you got 1 fissure separating the 2 lobes of the left lung. So, and an easy way to identify the borders of the lung is that usually the anterior border of the lung is pretty thin, because it houses the crucial organ, which is the heart, and then usually the right lung is quite thick and it's not as sad. And then you have a very important structure that would be helpful in identifying which lung is this, which is the lingula, which is present on the left lung. It's like a tongue, basically. And then we'll talk more in details in the next slides about the vessels organization and so on and so forth. So, anatomy of the lung. As I said, we got lobes, so three lobes on the right lung and 2 on the left lung, and then we got 2 fissures dividing those. So can someone tell me what fissure is pointed at by the red arrow? So it should be the transverse fissure, and then we got the oblique fissure here.
This is the horizontal fissure.
Yes, sir. You're correct. So this is the horizontal fissure, and then we got the oblique fissure. So, quick question. This is very important. This is usually in each and every OSPE station. They won't ask you specific questions first. They usually ask, what is this? Give me an orientation. So, which lung is
a question.
Right. The left one.
Can you tell me why would you say this is the left one?
Because we have a lingula that's very prominent.
Yes. So, let me tell you the 3 ways I personally use. So, 1, the lingula. 2, the fissure. So usually the left lung, there is only 1 fissure in the left lung, but sometimes the fissures aren't very clear. So usually the left fissure is going like this from left side down, and then the organization of the vessels. So in the left lung, it's artery, bronchus, vein. So ABV. Left lung, sorry, it's ABV, and then the right lung, it's BAV. So as you can see here, it is the left lung. You can see it's artery, bronchus, and then so if you need so you'll get access to, yes.
If in the OSPE it was not very clear which is which, how are we supposed to know?
You mean the vessels or the fissures?
لا اللung نفسه, if they put it in a يعني in a very weird orientation, how are we supposed to know?
Or you need to define it from these factors. يعني أول شيء you can imagine it. تعرف إن هذا زي ما قلت لك a thin border is usually anterior, and the thickest. So you can imagine it if you flip it, and then you got the lingula, you got the organization of the vessels, you got the fissures. Trust me, if they won't bring you an impossible question, because this is info. We gotta learn. So you gotta look, take your time, identify your time, and go from basics up. Everything should make sense when you solve it. That's the best piece of advice I could give you for an OSPE. Please make sure everything makes sense.
They also mentioned in the lab a good way to define if it's the left or right lung by putting your thumb on the hilum, seeing which thumb will go to the hilum, and the way you hold it is for example, my left thumb is on the hilum, so it's the left lung. If it's on my right, it will be on the right.
Well, that's actually quite helpful. We haven't had that in our batch, so y'all are the lucky ones. So that's another way. So you got a lot of ways to identify. Just when you don't know it, just a general piece of advice: do not panic. Take a look, go through the basics, and inshallah, try and solve it, because everything should make sense. Okay. So let's move on. Thank you for the answer. So this lung, is it right or left?
This looks like a right lung.
Yes, so you're right. So as I said, there are two fissures here. I don't know if they're very clear, but as I said, if you can't identify them by the fissures, just use the other way. So you got, usually in the right lung, the fissure goes this way, so up to the right, and then you can see the organization of the vessel. So you got it's BAV, so bronchus, artery, and then vein. And if you can see here, there is no lingula. So a very important tip: the ligament around the hilum has a dead space, recess, which is useful for what exactly? Does anyone know? Does anyone know? Has an idea about that? So usually when we're running, for example, we need space so the bronchus can dilate, the blood vessels can dilate. So if you do not have space and the vessels want to dilate, that doesn't really happen. But if you have some dead space that can accommodate the vessels when they dilate, that will be very functional. So that's why we do have some dead space in these areas. So let's now talk about lung impressions. This is pretty rough, but let's start with the basics. The left one, is it right or left lung?
This is a left lung.
Yes, you can see the lingula, the organization. So the first impression here, what do you think it is? So left lung, what's usually on the left lung? So usually you'd find the aorta, the arch of the aorta here. And then going down, it should be the descending aorta. And then, as you see in the first picture, you have something called the cardiac notch, which usually accommodates the left ventricle. So, and for the picture, you can see it's a right lung. We have a lot of different impressions. As you can see here, we got the azygous vein groove, then we got the brachiocephalic, which will then translate to this SVC when it merges with the other veins. You got also the esophagus impression, and so on and so forth. Usually those are brought on models. They're not brought if they're not clear on the cadaveric lung. So let's jump into something very, very fun. So thoracic vertebrae. As we just explained, the ribs, and this is not quite different. They also have different shapes. So we're usually going to compare thoracic vertebrae with lumbar vertebrae. So starting with the thoracic vertebra, the first thing you look at is the body. So the body is usually heart-shaped. It might not be clear in this slide, but when you look at the lumbar one, and you heard it's a kidney shaped, you'd see, okay, this actually looks like a kidney. So it's a really great way to differentiate it. And then you got the demifacets. So as you remember, we said that every rib attaches to superior to the vertebra above it. So same thing for the same thing for the vertebrae. So the first facet here would attach to the corresponding one, and then the one would be the rib below it. So if this is rib 5, this would attach to rib 6 if this is T5. And then you can see that then you got the transverse process with attaches to the tubercle of the corresponding rib. So if it's rib 5, T5, rib 5. And then you got the spinous process, which is quite long. It's usually, that's because it's very important for protection. Okay, so we got some exceptions. Usually T1 has only one complete facet. There is no demifacet because you only have one that's attaching to it. And also you got in T10 to T12, you got also one complete facet because of the position of the ribs. Also, now that's very important. You got the lumbar vertebrae. They're usually kidney shaped. There are no articulation. The spinous process is shorter. This is very important. If you got a question, you'd have so many models of vertebrae and ask you what is this vertebra and give me 2 differentiating points. Just an example of a question. you'd say maybe it is a lumbar vertebra, it's kidney shaped, no rib articulation, and so on and so forth. Everything is clear up to now?
Yeah, everything's clear.
Good. So let's jump into a different topic. So let's talk about the nasal cavity. So for the nasal cavity, it's quite simple. So you need to know the borders, the conchi and the meatuses, and what do they open into. So usually got the borders of the nasal cavity. We got the floor, which is the hard palate, the roof, which is the ethmoid bone, and we'll have a significant clinical thing about the ethmoid bone in the next couple of slides. We got the lateral walls, which are laterally, and the medially the septum. Then you got conchi, which basically means an elevation. It's three elevations in the nasal cavity. We got superior, middle, and inferior conchi, and then you got something called meatuses. Meatuses basically mean an opening. Okay, so you got corresponding to each and every meatus. Each and every conchi, you got a meatus. So for the superior meatus, it only opens to one sinus, which is the posterior ethmoidal sinus. For the middle meatus, it opens to almost everything. So frontal sinus, opening of the anterior ethmoidal sinus, and the maxillary sinus. And for the inferior one, it's very, very critical. It opens to something called the nasolacrimal duct. This is duct which carries the tears when you cry, when you're cutting your favorite onions. That's how you cry. They basically, the nasolacrimal duct moves the tears up to your eyes. So we're talking about the same thing, but it's in a model. As you can see here, I know the red labels aren't quite focus, but as you can see, you got the superior conchi, you got the meatus, and so on and so forth. So usually, the clinical parts, in the ethmoidal bone, there's a very, very, very small opening that opens through something called a cribriform plate. It's a small opening that the olfactory nerve goes through it. So when someone has significant bone fractures to the ethmoid bone or facial damage, the olfactory nerve can be damaged, so they lose their sense of smell. Now let's go to the larynx. Larynx is basically a group of cartilage. So usually you got the cricoid, the thyroid, the corniculate, and the epiglottis. They create the larynx. And for the vocal cords, basically what you need to know is the naming muscles is usually through the cartilage they're attached at, so like cricoarytenoid. So it's from the cricoid cartilage up to the arytenoid cartilage. I need to know a couple of functions here. So for the posterior cricoarytenoid, it abducts the vocal cords, and for the cricothyroid, it tenses the vocal cords by pulling the thyroid here forward. All of the muscles of the larynx are supplied by the recurrent laryngeal nerve, except the cricothyroid. Can you tell me what would happen if the recurrent laryngeal nerve is damaged?
We get voice hoarseness.
Yes,
Because we can't move the vocal cords properly.
Yes. And then what happens if you damage? Oh, firstly, what is the nerve that supplies the cricothyroid if it's an acceptance of the recurrent laryngeal nerve? It's a pretty tricky question.
Are we talking motor or sensory innervation?
It's motor.
Motor innervation is
there is
going
no
to be
sensory.
it's going to be the recurrent laryngeal, I think.
It's going to be it is the only exception. The cricothyroid is supplied by the superior laryngeal muscle. When someone gets that nerve damage, usually in thyroid surgery, they lose their voice become monotonous. That means the tone does not change. They like if they were screaming, if they try to change their tone, they cannot. That's what happens when you damage your superior laryngeal nerve. So let's do the ECG lab. So it's pretty simple. We're gonna compare the systolic and diastolic periods. We're gonna do inhalation and exhalation. We're gonna describe the changing from standing and then exercise. So for the first ECG, as you can see here, we're gonna talk about the systolic period, which starts from the QRS complex up to the peak of the T wave. Can you see my mouse? Should I put a pointer?
Yeah, we can see it. We can see it.
Okay. So sorry. Yes. So and then the diastolic is usually the after repolarization. It's from the peak after finishing the peak of the T wave up to the peak of the next P wave. So usually the heart rate is 60 to 100. I think you've studied CVP enough to know that these information. So let's ask a question for the crowd. so the question says, inhalation causes increased heart rate. Why? Try and
Because
be
we're increasing afterload.
be more I don't want the book answer. Just try and imagine it, because not everyone's gonna remember increase of afterload. So basically, when you inhale, you create negative pressure, which and then you provide a lot of oxygen in your bronchi, in your alveoli. So you want a lot of blood, so you can use the oxygen. So basically, by creating this negative pressure, you suck in blood to your lungs, which initiates, which we tried doing that, so you don't actually suck blood, so you try to do that, so a sympathetic activation happens, and then your heart rate increases, so we can pump more blood to your lungs. And as soon as you exhale, you only excrete CO2, so you don't need to store the blood anymore, so the heart rate goes down, so for the blood to go back from the lung to the left atrium, left ventricle, then to be pumped to the rest of the body. So as I said here, inhalation usually interacts with sympathetic nervous system, and then it increases heart rate, and exhalation is usually linked with parasympathetic and decrease of the heart rate. So for the standing and the this is a question I think that a lot of people had mistakes on. So after standing up, your heart rate usually increases. Can someone explain why?
Because the blood is going to start pulling down.
Yes. So down, no more blood, baroreceptors don't fire anymore. That means decrease in sympathetic and increase in parasympathetic. So your body tries to compensate by increasing the heart rate and the blood pressure. That's great. And then after exercise, you basically trying to pump blood to your muscles, because you're using them a lot and you require oxygen for muscles to work. So then if you do vigorous exercise, you require more blood flow to these muscles, so your heart rate will be up. Then when you rest, it will be down. I think everything here makes sense. So let's jump to my favorite part, which is the histology. I know it's controversial, but histology is really fun when you get to know it. So let's start with cardiac cell histology. So basically, this is one of the rare slides that I'll be explaining a lot. I love asking, especially in histology, because that's how information usually sticks. So basically, cardiac cells. I remember in foundation you took different muscle cells. So for cardiac cells, it has a lot of features. One, it's usually the nucleus was mostly in the center. You have striations like skeletal muscles. And what signifies cardiac cell personally is the presence of intercalated discs. Those are very, very prominent when you're looking at macroscopic picture. You can see them. You can see them here. You can see them here. You can see them here. So basically, the muscles go this, so they attach like that. And then you got also your capillaries, which you can see the RBCs are passing one next to another. So can someone help me? So this is a picture of the heart. You got 1, 2, 3, the layers of the heart, epi, myo, endocardiums. So, and then can someone tell me why is this side thicker than the other? And
This side is thicker because it's the left atrium.
Yes, it is left ventricle. So basically,
Sorry, yes, left ventricle.
yeah, usually when you see someone with big muscles, you expect them to be strong. Unlike if you see someone very skinny, you do not expect them to be as strong. Same thing for the heart. If you want to pump blood to the lungs, which are relatively close by, and you want to push the blood up to your extremities, that's more of a distance, so it requires more power. So that's why you got more muscle on the left side. And then for 12, it's something very interesting, which is the capillary muscles, which give attachment to the chordae tendineae of the valves. And then now let's start focusing on specific parts of the heart. So we took this part of the heart. Does anyone know what this part is?
This is the epicardium.
Epicardium, you're correct. So this is the epicardium of the heart. It has many components. Firstly, you have your coronary arteries and veins, and then you got the different. So basically the layers of epithelium on the external and internal surfaces are called differently. So if we're talking about the endothelium, we're usually talking about endocardium, we're talking about endothelium. And if you're talking about epicardium, we're talking about mesothelium. So you can see the different layers. You got the lumen of the pericardial cavity. You got the mesothelial cells here. You got the mesothelial connective tissue. You got the adipose tissue here, and then you got the working myocytes up there. So let's zoom in inside the heart. So you can see the lumen of the ventricles is here. Let's zoom into the endocardium. So you got our blood here, which is usually pumped in the lumen of the endocardium. And then you got your endothelial cells, your basement membrane. And what's D exactly? Does anyone know?
D is Purkinje fibers.
So yes, perfect, Purkinje fibers. So Purkinje fibers are these weird looking white cells. So they're basically they look like a myocyte, but they're very dilated and very white. The whiteness is filled with glycogen, which stains usually white. It doesn't stain. So those are the last conductants of the heart. So you got SAAV, intraventricular septum, and then you got your Purkinje fibers, and then you got the Purkinje endocardium junction, and then you got your working myocytes. So classifications of arteries. This is fun personally. I've loved those. So you got different. So for the arteries, you got large, middle, small, and then arterioles. Let's organize them by what I'm wearing now. So usually when you try to identify vessels, you look at the three tunics or the three layers, basically closed. So you got tunica intima, tunica media, and tunica adventitia, or tunica externa. So tunica intima is basically a very smooth surface, like wearing an undershirt. It basically helps the flow of lumen. Does not provide as much protection, but it makes sure that there is no turbulence on the surface. The surface is smooth, so blood can flow peacefully. And then you got the tunica media, which is the layers of muscle, which is basically the Kevlar bulletproof vest I'm wearing under my hoodie, which is basically the amount of layers of muscle we got, and they really help with usually classification of the different arteries. And for the last layer, which is the tunica adventitia, it's like wearing a light hoodie like I'm doing. It just helps you stick to the organs that you're close to. You don't want blood vessel to be flying around, of course. So let's start by taking the large or the conducting arteries, such as the aorta. It's very elastic because it accommodates for a great amount of pressure coming out from the left ventricle and distributing it to different parts of the body. Am I speaking too fast? Should I?
If you could slow down a little bit.
Yeah, sure. So you got the large vessels, which are the aorta. They're very elastic, and they have 30 to 40 layers of muscle, and they're usually close to the heart, and they're analogous to the superior vena cava and inferior vena cava. And then you got the medullary muscular arteries. They're usually lesser in smooth muscle layers, so 10 to 20. And then they got internal and external elastic lamellae, as you can see here. This is internal elastic lamellae, and then the external elastic lamellae. That's a very easy way to identify them. And for the small muscular arteries, they're usually further from the heart, and they only have internal elastic lamellae with around 10 layers of small muscle, give or take. So for arterioles, so they usually control. They're called also resistant arteries because they really affect your blood pressure. You can hardly differentiate the different tunics here. So it's usually 1 to 2 smooth muscle layer. You can see the endothelium quite visibly here. You cannot see the borders, which you saw here. It's not that prominent because it's a very, very small vessel. So and you can see here, usually when you compare arteries and veins, veins do not face a lot of pressure, so they're usually more collapsed. So they're quite clear when you see them. If you want to compare them in histological slides. So
I have a question regarding this last slide.
Sure.
Not this one, the one before.
Here you go. This one?
Yeah, this one. How can I tell the difference between external elastic and internal elastic lamellae?
So usually the external elastic lamellae is between the tunica muscularis or the tunica media and the tunica adventitia. That's the external lamellae, and the internal lamellae is between the the tunica intima and the tunica media. So you can see them here. So if you can see here, this is only an internal elastic element. You don't see this on the junction of the here. You don't see them outside of the small arteries. You only see them in the middle-sized arteries.
Okay, got it.
Question. So let's touch upon capillaries. I didn't see them in your lectures mentioned a lot, so I'll just touch upon them. So you got 3 types of capillaries: continuous, fenestrated, and sinusoidal. It depends on the amount of leakiness they got. So usually in the continuous, it's the most prominent type of capillaries. They're most prominent everywhere in the body. They don't allow for big molecules to pass, only the small molecules. Fenestrated capillaries, fenestra in Latin is just windows. That means they got so bigger molecules can pass through them, and discontinuous don't have a continuous basement membrane, so they're very leaky. So they're usually present in liver, spleen, and bone marrow. So let's go to pulmo. So what's the first thing that you face when you talk about pulmonary breathing? Nose. Firstly, you got the keratinized stratified squamous, which is not here, and then let's go up a bit and talk about the respiratory part of the nasal cavity. So, can anybody know what are 1 and 2?
1 I think is cilia, and 2 is pseudostratified.
Yes.
Columnar
It's respiratory epithelium. It's pseudostratified ciliated columnar epithelium. You're gonna see that a lot. 3 is usually where vessels are. And then you got the lamina propria of these cells. You also got the olfactory cells here, which is also part of the nasal cavity. And then you got their lamina propria. And then now we're going down a bit to the trachea. So you got 2 structures here. You got one of them is the trachea and one of them is the esophagus. Can you tell me which one is which?
1 is the trachea because we have a C-shaped ligament, and 2 is the esophagus.
Perfect. So usually the trachea is C-shaped rings of cartilage, and then the esophagus, where where food goes from the mouth up to the stomach, is usually very muscular because it controls the bolus of the food. You don't want food just going down directly to a pool of acid. So it's cartilaginous rings. Easiest thing is to see the cartilage, and then you got the esophagus, which is pretty muscular. And then for the layers of the trachea, you got mucosa, submucosa, and then you got the cartilage and the adventitia, as you can see here. This is the epithelium, basement membrane. Then you got the submucosa, the cartilage of the cartilaginous rings, and then you got the adventitia. And you got here. We're zooming a bit. So can someone tell me what kind of epithelium is this, and what's the function of structure 2?
So the kind of epithelium, this is pseudostratified ciliated, and for B, structure 2, I think, is a goblet cell, and the function is that it secretes mucus.
Perfect. That's perfectly correct. So it is a respiratory epithelium, which is ciliated pseudostratified columnar epithelium, and you got goblet cells that secrete mucus. So now we're gonna try and imagine this. It's a pretty easy to identify the next part. So you got the respiratory part of the respiratory system. So it starts with the interpulmonary bronchus, which is very similar to the trachea. It's not part of the respiratory part. Then you got the respiratory bronchioles, and then alveolar duct sacs, and then you go to alveoli. You're gonna start seeing some changes in structure, starting from the respiratory bronchiole. The epithelium is gonna change from the respiratory epithelium to more cuboidal, then squamous. Then you don't have then you only got alveolar cells. You're gonna see the decrease of numbers of cartilage. You won't see cartilage anymore. You won't see goblet cells. They'll be replaced by something called club cells or Clara cells. They won't be secreting mucus anymore. They'll be secreting something else called surfactant. So let's start. Can someone firstly tell me what is this? And let's identify the numbers together.
Okay, so I think 1 is a some type of macrophage or like lymph.
That's a great guess. I haven't jumped into that. So 1 is something called BALT, or bronchus-associated lymphoid tissue. That's really great. And then you got 4, which is the chunks of cartilage around the intrapulmonary bronchus. 2, you got the epithelium. If you can see changes starting to happen, it's becoming less stratified, and it's becoming smaller. And then you got the lamina propria of the cells. Then let's shrink it a bit more. Now you go to the respiratory bronchioles. You can see that the epithelium here is becoming more cuboidal. You do not see goblet cells anymore. So it's the structure is going down, the pyramid is going down. So keep your imagination thinking like that. So what are the following? So 1 and 2, it's something bigger becoming something smaller, as you can see here. 1, 2. Can someone tell me?
1 I think is a bronchiole, while 2 is a alveolar sac.
Well, one is an alveolar sac and 2 is one is an alveolar duct and 2 is a sac. As you can see in here, this is too small. This is too big of a magnification to see a bronchus. So we're focusing here. So you might call all of this as a bronchus, and then this part as an alveolar duct, and then it goes deeper to become a sac, and then this is a sac, and then you can see the many alveoli here. We'll focus on them later. So as you can see, the epithelium is starting to go down. So now let's go to the smallest part of the respiratory system, which are our alveoli. So our alveoli are made of 2 types of pneumocytes, type 1 and type 2. Type 1 is is squamous, very small, and it's responsible for gas exchange because it's super thin, closest to the blood vessels, and it allows the passage of oxygen through these thin membranes. And then you got the alveolar cells, which are the type 2, which are the more rounder ones. Those ones secrete surfactant, which is very important to minimize surface resistance and minimize damage to these bronchioles. And then the last part is something called alveolar macrophages, as you can see them here. They're usually stained weirdly because they have parts of carbon in them, because if they check if you have in your breath anything full of bad guys. So it's something here, as you can see them. And then that's mostly it. Thank you so
I have a
much.
question regarding the last slide, if that's okay.
Sure. This one?
Yeah. So how can I tell the difference between a Clara cell or a club cell and type 2 alveolar cell?
You don't see usually so you don't see Clara cells. So the Clara cells stop after the alveolar ducts and sacs. So you start with goblet cells in the trachea, and then you go to Clara cells till the ducts and respiratory duct and sac, and then khalas, you only got the type 2 cells.
Okay, and Clara cells release surfactant as well as type 2 alveolar cells?
Yes.
Perfect, thank you.
Thank you so much. So thank you for your time. If you have any questions regarding this review or any other topic in regards of CVP or any other block, I'm very open to help. And if you have the time, please fill the form. It won't take more than a minute to help us improve, inshallah, in next sessions. Thank you for your time. If you have any questions, I'm here.
Thank you very much.